Time now for Morning Rounds, our look at the top medical news of the week. Joining us are CBS News Chief Medical Correspondent Dr. John Lapook and CBS News contributor Dr. Holly Phillips.
First up this morning, a story that made headlines all over the country. Controversial new guidelines for preventing heart disease. John?
Vanita, there could be a major change in the way doctors prescribe cholesterol medication for millions of Americans.
A generation of doctors and patients has focused on specific targets of cholesterol levels when using statins. But the new guidelines say when it comes to preventing heart attacks and strokes, there's no magic number. Dr. Neil Stone led the panel.
We did a careful study of what number we should use. Was it 100? Was it 90? Was it 80? Was it 70 for LDL? You know what we found? We couldn't find a single number that made any sense.
So rather than adjusting the statin dose to reach a certain cholesterol level, the panel now advises doctors to prescribe either a moderate or high dose depending upon the patient's risk factors for cardiovascular disease. The group says patients may benefit from statins if they have a history of heart disease or stroke, LDL or bad cholesterol of 190 or higher, the onset of diabetes between the ages of 40 and 75, or a 10-year risk of heart attack or stroke of at least 7.5%. To measure that risk, the panel created a calculator that considers factors other than just cholesterol, including ethnicity. For example, a 50-year-old white male with treated high blood pressure, total cholesterol of 220, and good cholesterol of 45 has a 10-year risk of cardiovascular disease of 5%. Statin treatment may not be warranted, but for a man who is African American, a group known to be at higher risk, the exact same numbers give a risk of almost 9%. A level that meets the panel's criteria for treatment.
Everyone is different. We all have our risks and our individual factors that make treatment either more beneficial or may make treatment more difficult. And to deal with that, we're urging a patient-clinician discussion.
So, John, no more monitoring LDLs. I feel like this is a huge leap of faith for some patients.
It is, and it's a huge change. And the reason why they did these changes in guidelines is there's so much confusion. I'm going to try to oversimplify it maybe. Basically, the panel is saying there's two groups, the people at high risk of heart disease and stroke and those people at low risk. If you're at high risk, it may be worth it to take a statin because you're going to significantly decrease that risk. But if you're already starting off at a very low risk, you could take a statin, but it's only going to lower your risk a little bit more, so it may not be worth it to take the statin for decades.
So are we shifting away now from cholesterol count essentially just to a healthier lifestyle?
Absolutely. That is the bottom line of all of this. And they're specifically talking about the person, for example, who is bragging about their LDL, their bad cholesterol of 70, very low, but they're obese, they're not exercising, they're eating potato chips, they're smoking, maybe they have high blood pressure, and they think falsely that they're protected, and they're really fooling themselves because they're an accident waiting to happen.
Statins affect so many people, so it really is interesting news. Also this week, there was another twist on prevention and healthcare costs. Many employers are getting aggressive about forcing workers to get healthy. New rules go into effect in 2014 that will allow companies to raise health insurance fees for people who smoke or are overweight. The goal is to reduce costs, but the penalties are raising concerns about individual medical choices and privacy. So, Holly, we hear so much about this nanny state, governments forcing people to be healthy. The real question is, is that what this is headed toward?
Well, these changes really are widespread. About 40% of companies by next year will have some penalty programs in place, and it's predicted that 60% the year after. So we are seeing much more of this. It's really because for the last decade, many employers have tried to do positive enforcement, saying, okay, here's some free smoking cessation programs. We'll give you gift cards if you lose weight. Here are free gym memberships. But ultimately, they're finding that that's not working. So now they're looking at the other way of imposing penalties.
But aren't there privacy concerns here, Holly?
There are tremendous privacy concerns, and that's actually what worries me the most, which is really if employers are entitled to follow your smoking status, follow your weight, follow your overall health status, it's easy to see how it's a slippery slope where they could preferentially hire people who are healthier and even potentially fire people who are less healthy or have disabilities. That's really a huge concern.
So who's most likely to be affected when these companies meet these goals, if they meet them?
Right. Well, Vanita, that's another concern. The people who are most likely to be affected are the lowest wage earners because statistically they are most likely to be overweight or smoke or have poorer health. So essentially, we are punishing people who can afford it the least because they are the lowest wage earners. While I really support trying to get everybody healthy and to contain healthcare costs. I see how this can be a really, really controversial issue of how employers are actually going to do it.
There was good news this week about school lunches and snacks for kids. A study from Michigan State University finds schools that offer healthy foods in the cafeteria or in vending machines increased students' consumption of fruit by 26%, veggies by 14%, and whole grains by 30%. And many kids in the study stayed with healthier diets even when they were not at school.
Now, some alarming news about potential abuse of prescription painkillers. A research team at Beth Israel Deaconess Medical Center in Boston examined data from more than 1 million hospital admissions across the country. They report that more than half of all non-surgical patients are prescribed narcotic painkillers in the hospital, often in very high doses. And many of those patients were still getting the medications on the day they went home. John, I feel like we keep hearing stories about stuff like this. How widespread is this problem?
Well, it's a huge problem. I really think one of the problems is that we doctors are not being educated well enough about how to deal with chronic pain. I know when I was in medical school, it was sort of how much do you write for the narcotic? But there are other things. There's alternative medicine, integrative medicines, there's massage, there's acupuncture, and there are pain control services now. A lot of hospitals have these that talk about all the different modalities. I think right now it's so much of an adversarial relationship often between the patient. They're trying to get it. You're being worried that you're going to give them too much.
Yeah.
If you're a patient, though, Holly, I mean, how do you know if the medication you're being given is too strong?
One of the main things is to ask. If you're in the hospital and you're experiencing no pain, or even if you're feeling a little sedated or groggy, ask, am I being given pain medicine? How much? And I'm actually not experiencing pain. Do I really need it? The other very important thing is if you're discharged with bottles, with medications, make sure you only take your pain medicine as needed. You do not need to follow the bottle which says 2 every 4 hours. Only take it as you feel pain.
Finally this week, if you're one of those people who walks around humming show tunes, you might be happy to hear this. Researchers at George Mason University in Virginia organize music sessions for elderly nursing home residents 3 times a week. They asked half the patients to sing along with the show tunes, and the other half just listened. Those who sang along had improved scores in cognitive tests after the experiment ended, even if they were suffering from severe dementia.
John, you're always humming show tunes, so I'm not worried about you.
Let's hear something.
I was told by the producers, don't break out into song. But this rings so true because I was at a nursing home in Brooklyn, and I was sitting at a piano with a woman who has Alzheimer's, and we were singing together, You Are My Sunshine, and she just lit up because she knew the words.
Yeah.
It was such a deep-rooted memory that it felt good. She knew the words.
That's great. I would say let's sing to break, but I'm tone deaf. So Dr. John Lapook, Dr. Holly Phillips, thank you both. Great to be here.